Right. So a very good evening to all of you. So yes, Kapil, good evening. So in this session, I will try to take up some of the very important images in the general medicine, right? So mostly I will try to confine myself regarding the images in the cardiology, right? But we will have some mixed based images, and these images definitely we can these images in the upcoming INI-CET or FMG or NEET PG exam, right? So let us start with the important images. So before starting the session, I am myself Dr. Rajesh Gubba. I am the general medicine educator on Unacademy platform. Okay, right. So you see the first question. In ingestion of the product shown in the photograph can lead to ingestion of the product shown in the photograph leads to hyperkalemic alkalosis, hypokalemic alkalosis, hypokalemic acidosis, hyperkalemic acidosis. So what will be the abnormality that you can expect upon ingestion of these particular sticks? So can anyone identify and tell me what are these sticks? Yes. So who will be the first person to make an attempt? Right. So if you don't know, then let me tell you. So these are right. These are your licorice. Right. These are your licorice sticks. And this particular licorice, please remember, they have a substance called glycyrrhizin. Right. They have a substance called as the glycyrrhizin. Now, what does this glycyrrhizin does? This glycyrrhizin, it is associated with the low potassium levels, right? It is associated with low potassium levels and as well as the alkalosis. So a very important question that you have to learn here is ingestion of the licorice sticks will make the individual to develop what is called as hypokalemic alkalosis, right? So this is the first question, right? So this is a quick rapid revision of the images because we are near to the exam. We will not waste much time on the individual image. Okay, right. Now association of the condition shown in the photograph includes all except association of the condition shown in the photograph includes all except Turner syndrome, Down syndrome, ventricular septal defect, patent ductus arteriosus. But first of all, yes, Vaibhav, can you tell me what is the image that you are seeing there? What is the image that you are able to make out? Right. So this particular image, it is your coarctation of aorta. Right. So you can make out the coarctation here. Right, so you are able to make out the coarctation of aorta. Now this particular coarctation of aorta, it is associated with the Down syndrome, right? In patients with Down syndrome you have this coarctation of aorta. Okay, so please remember this is a very important point. Now let me tell you what are all the common heart defects that you can see in Down syndrome. So what is the answer to this question? The answer to this question is B. Coarctation of aorta is seen, sorry, what is that we are discussing? It is not seen in association with the Down syndrome. I'm very sorry for this. It is not seen. The question asked is except. And now let me tell you what are the cardiac abnormalities that you will have in patients with the Down syndrome. You will not have coarctation of aorta. Coarctation of aorta can be seen in association with the Turners, can be seen in association with the VSD, can be seen in association with the patent ductus arteriosus, but not the Downs. Now, what are the cardiac abnormalities that is associated with the Down syndrome? That is endocardial cushion defects. That is atrioventricular septal defect. That is one. And then VSD. Next, patent ductus arteriosus, and then tetralogy of Fallot. So these are all the cardiac abnormalities that can be seen in association with the Down syndrome. But is not your coarctation of aorta, right? What has been shown you in your image for you, it is your coarctation of aorta. Okay, now coming to your Turner syndrome. What are the cardiac abnormalities that can be associated with the Turner syndrome? In Turner's, you will have this coarctation of aorta, and there can be also bicuspid aortic valve. Okay, so these are the cardiac abnormalities that can be seen in association with the Turner's and as well as the Down syndromes. And in Turner's, you can also have the aortic arch anomalies, and there can be also PAPVC. What do you mean by the word PAPVC? That is partial anomalous pulmonary connections. Okay, so pulmonary veins, instead of getting connected into the left atrium, right, they get connected into the superior vena cava or to the right atrium. Okay, next, so physician shown in the photograph, what is he known for? Right, because sometimes you can get the images also like father of USG, father of MRI, father of CT scan, and father of medicines. Who is he? Yes, Vaibhav, what is your answer? Father of what? Very good, Maria Khan. So he is a father of medicine. And Alok, who is he? Yes. So may I know who is this great person? Right. So he is Hippocrates. He is your Hippocrates. Okay. Very good, Maria Khan. Now, so and at the same time, let me tell you who is the father of ultrasound, who is the father of MRI, and father of CT scan. See, sometimes you can get these type of questions also. Okay, right. Father of ultrasound is John J. Weil. Father of MRI is Raymond Damadian, and father of CT scan Godfrey Hounsfield. Right. So these are some fathers that you have to remember. Okay. Now this is another very important image-based question. Abdomen must be compressed for how many seconds for the reflex to appear? Now what is the reflex he is doing? You see here, this is the reflex he is trying to do, and he is observing something in the neck. So abdomen must be compressed for how many seconds for the reflex to appear? Yes, Vaibhav. So in medicine, like everything. Right, who is that? Krishna Bhatt. Very good, Krishna Bhatt. So what is the name of this particular reflex? This is called as the hepatojugular reflex. Right, this is called as the hepatojugular reflex. And in order to have the appearance of this hepatojugular reflex, you need to compress the abdomen for nearly around 10 to 15 seconds. So with that, you can observe that there will be a raise in the JVP. Now, can anyone tell me what are all the conditions where you have positive hepatojugular reflex? What are all the conditions where you will have positive hepatojugular reflex? So yes, may I know quickly, like what are the conditions you will have positive hepatojugular reflex? Right, so positive hepatojugular reflex, let me tell you. Yeah, so Maria Khan, you should tell first right heart failure. Right, you have said congestive heart failure. That is not it is not the point that it is not correct. It is also correct, but the first thing like what you need to say is the right heart failure. And the other conditions where you can have the hepatojugular reflex being positive is you can have that in tricuspid regurgitation, tricuspid stenosis, constrictive pericarditis, restrictive cardiomyopathy. So all these conditions, right? Okay, now we will move on to the next important image. Yes. Severe stenosis of the valve shown in the photograph correlates with severe stenosis of the valve shown in the photograph correlate with. Yes. No. Vaibhav, it is not intense. Okay, so first of all, which particular valve we are talking about? What is this disorder? Yes, what is this disorder? It is your mitral stenosis, and we have only one learner answering correctly. Very good, Maria Khan. That is duration of mid-diastolic murmur. Duration of mid-diastolic murmur. See, how will you assess the severity of mitral stenosis? Right, we have two ways by which you can assess the severity of mitral stenosis. Number one, duration of mid-diastolic murmur. So more long is the duration of the mid-diastolic murmur, more severe is your mitral stenosis. And the other thing is the A to OS gap. A to OS gap will also decide. Narrower is the gap, right? Narrower is the gap, more severe is your mitral stenosis. And let me tell you why you're asking why not intensity. The point is that intensity will not be the decision factor for your mid-diastolic murmur. Why? Because mid-diastolic murmur, it is a low-pitched murmur. It is not a harsh systolic murmur or a diastolic murmur. It's a low-pitched mid-diastolic murmur. So that is the reason why we don't take the intensity of the mid-diastolic murmur as a. Okay, right. Next, we will move on to the next important question. Yes. Diagnose the underlying medical condition by ECG change in the photograph. Hypokalemia, hyperkalemia, hypercalcemia, hypocalcemia. Based on the ECG change whichever has been given to you, please make out what is the electrolyte abnormality that is being shown to you. Right. So Alok says hyperkalemia. No. Why Alok? Why are you telling hyperkalemia? And Krishna Bhatt says hypercalcemia. It is not hypercalcemia. Now, where is your tall tented T waves, man? These are your T waves. This is not tall tented T wave. This is a small T wave. Normal T wave. This is a normal T wave. Okay, so I did not get the correct answer from any one of you except from Maria Khan. Very good, Maria Khan. So it is your hypocalcemia. Now, Maria Khan, can you tell us everyone what is the abnormality you are able to make out? Yes, Maria Khan, can you tell me what is the abnormality that you are able to make out in this ECG? So the abnormality in this ECG is long QT interval, right? Long QT interval. Very good, Maria Khan. It is your long QT interval. Now, where will you have, in which clinical condition you have long QT interval? You will have this in patients with the hypocalcemia. You will have this in patients with hypocalcemia, right? Now, whereas you take in patients with hypercalcemia, in patients with hypercalcemia, you will have short QT interval. It is not long QT interval. This will be short QT interval in patients with hypercalcemia. Okay? And in patients with hyperkalemia, you will have tall tented T waves. Right? You will have tall tented T waves. Okay? And in hypokalemia, you have the appearance of the U wave. So these are the ECG changes in your electrolyte abnormalities. So whatever I am telling you, it is just only the specific sign of that electrolyte abnormalities, and you have many other ECG changes in hyperkalemia and as well as hypokalemia. Okay? Right. Now, yeah. And so I said that there is long QT interval. I said that there is a long QT interval. Now you should know how much is the normal QT interval. The normal QT interval, it is around 360 to 440 milliseconds. Right, 360 to 440 milliseconds. That will be the normal QT interval. And when the QT interval is like, if it is like more than 440 milliseconds, that is the point we need to consider. It is long QT interval. Okay, right. Most common cause of unilateral condition of the foot shown in the photograph. Most common cause of the unilateral condition of the foot shown in the photograph. Right. So whatever has been shown to you, very good, Viber and Maria Khan and Krishna Bhatt, it is your venous insufficiency. It is your venous insufficiency. Now, can anyone tell me what is this Milroy disease? What is this Milroy disease? Any one of you? So Milroy disease, this is also a lymphatic disorder. Right, it is a lymphatic disorder. Very good, Gopika Sharma. So it is a lymphatic disorder where you have an obstruction, and that will also cause the swelling of the limb. Right. So venous insufficiency, that is one of the most important cause for the development of this pedal edema. Okay, right. So Milroy disease is a condition that affects the normal function of the lymphatic system. So what will happen in Milroy's? There will be impaired transport with accumulation of the lymph, and that will cause lymphedema or the swelling of the foot. Swelling of the foot. Okay, right. Then followed by that, see, recently I had a 53-year-old female presenting to me with history of bilateral pedal edema, and I have examined her and I have tried to do the basic investigations, right? Even though I was not very happy to do all the investigations, but the attender was insisting me to do that particular investigations. So she was like 53-year-old female with hypertension, okay, and she was taking Amlong 80, right? Amlong 80, and she's also diabetic, for which she's using metformin. Okay, right. This was the history with the patient. Then by taking the history there itself, I was in a suspicion that this amlodipine might be causing this the pedal edema. But with the for the satisfaction of the attender, like I have done one 2D echo also, right, which was absolutely normal, and liver function test where the proteins were normal, renal function test where the creatinine was absolutely normal. So always remember, this calcium channel blockers, mainly not all the calcium channel blockers, this amlodipine, right? So always whenever a patient is coming to you with a history of pedal edema and known case of hypertension, first you need to ask what antihypertensive the patient is taking, right? Amlodipine is more prone for this development of pedal edema, but we don't see the same with the cilnidipine again. We don't see with the cilnidipine again, but with amlodipine we have seen a good number of cases presenting with the pedal edema, right? Next, some more questions. Right, so yeah, a 36-year-old woman presenting to the rheumatology outpatient clinic with 2 months history of stiff hands and wrist. She mentions that the pain is particularly bad for the first few hours after walking up and is affecting her work as a dentist. On examination, the wrist, metacarpophalangeal joints and proximal interphalangeal joints are swollen and warm. JVP tracing is shown. What will be the cardiac examination finding in this patient? Pregnancy you will not have, yes Subbu, pregnancy you will not have unilateral pedal edema. Pregnancy it will be bilateral pedal edema. Your B option was pregnancy, right? Now this is a patient, 36-year-old female with rheumatoid arthritis. Right, very good Siddharth. The answer is the pericardial knock. Yes Siddharth, what is your diagnosis, Siddharth? What is your diagnosis? Right, the diagnosis is constrictive pericarditis. Diagnosis is constrictive pericarditis. Yes, Subbu is asking why not lymphedema. Lymphedema, it is not the most common cause for unilateral pedal edema when you have the venous insufficiency in the options. So first you need to go with the venous insufficiency as a common cause for your pedal edema, then followed by the lymphedema. Okay, right. So here the diagnosis of this particular patient is the constrictive pericarditis. Now why is that you need to consider the constrictive pericarditis? Because there is presence of deep Y and as well as the deep X descent. And in patients with rheumatoid arthritis, one of the cardiac manifestation is constrictive pericarditis. So if you take the cardiac manifestations in patients with the rheumatoid arthritis, constrictive pericarditis is one. Premature atherosclerosis is the second one, and the third important thing is they can also develop cardiomyopathies. So these are the and pericardial effusion. These are the cardiac abnormalities that you will have in patients with the rheumatoid arthritis. So because the JVP tracing is showing deep X and as well as Y descent, in cardiac examination you will have the pericardial knock, and this pericardial knock, it is a diastolic sound. This is also an important multiple choice question, that pericardial knock is it's a diastolic sound. Okay, next, yes, and this is one of the last image of this session. A hypertensive patient is having severe chest pain, after which he developed unilateral ptosis and as well as the hemiparesis. The chest X-ray of the patient is shown below. What is the clinical diagnosis? I think I am, one second. Yeah. What is the diagnosis of this clinical scenario? Right. So what is that you are able to observe? You are able to make out that there is presence of wide mediastinum. You are able to make out wide mediastinum. Okay. And the individual is having chest pain, unilateral ptosis, and as well as the hemiparesis. So this is a very classical history of the aortic dissection. This is a very classical history of the aortic dissection. So in aortic dissection, you will have chest pain, right? And why is that you will have ptosis and as well as hemiparesis? Remember, if this particular dissection, if it is occurring in the arch of aorta, right, if the dissection is occurring in the arch of aorta, what will happen is the blood supply to the brain will get cut off, because the carotids are the one which are originating from the arch of aorta, and thereby the individual will have the hemiparesis. Okay, so the answer to this particular question is the aortic dissection. Right. So these are some of the important image based questions related to your cardiology. Right. So in the upcoming sessions, I will try to take up as many images as possible of the individual system every day on the YouTube. So you can follow these YouTube sessions for images for general medicine for your upcoming exam. Right. So thank you very much. Right. I hope this session is useful to you, and see you in the upcoming sessions.